afternoon and welcome. My name is Christy Barton-Hagen, and I'm the president of the League of Women Voters, Leelanau County, for 21 days, 6 hours, 15 minutes, yes. Not like I'm counting them. The League of Women Voters is a nonpartisan political organization that encourages informed and active participation in government, works to increase understanding of major public policy issues, and influences public policy through education and advocacy. We never ever support or oppose candidates or parties. Men and women who are 16 years of age and American citizens may join the League. The Leelanau League currently has 179 members, of which 35% are men. More information on the League may be found at our website, lwvleelanau.org. Dues are $60 a year or $90 for a family membership. Membership applications can be found online at our website and also on the table in the hallway. Before we begin, I just want you to know that our next public forum will be at noon on Wednesday, June 6th. It is called Care for the Planet, because your health depends on it. Please mark your calendar and join us then. Following the presentation today, we will take a 5-minute break and then convene for our League member business meeting. Today's forum is entitled, Is Our Healthcare System Broken? I would like to introduce Sue Miller, who will introduce our speaker.
Thanks, Christy. When I helped to organize this forum today, I had little idea that I was going to be a consumer of local healthcare services. So you'll have to excuse my my cart and my lack of speed in getting out of here. But I did want to take this opportunity to introduce two people who I've gotten to know through the planning process. And I thought I'd start out by just saying that when I volunteered to do this, I knew one person in the county who I regarded as an expert on healthcare systems. And that person, Kevin Seitz, spoke with us in February. But that discussion led to a variety of referrals of people who might be able to help us out with this forum. And it'll be no surprise to most of you here in Leelanau County that we have many residents who have great experience and knowledge in countless areas. Our two presenters today, Dr. Barb Conley and Dr. Ed Dolan, honed their expertise in the field of healthcare before moving here and are sharing some of that expertise with us today. I'm going to introduce both of them now, and I just want to give you a little information on the format. We're going to have Dr. Conley start the presentation. We're going to end with Ed Dolan, and then please save your questions and any thoughts you might have on the topic until that presentation is done. And we'll be rotating around the audience and trying to get to all the questions. I'm going to start with introducing Dr. Conley. She is a medical oncologist who received her MD from Michigan State University. Until July of last year, she was Associate Director of the Cancer Diagnosis Program. That's a division of the Cancer Treatment and Diagnosis Program of the National Cancer Institute in Maryland. Her work there focused on the connection between clinical diagnostics and clinical trials. I simplified that because it was a very complicated description. She also served as professor of medicine at the University of Maryland and chief of the Division of Hematology and Oncology in the Department of Medicine at Michigan State. Dr. Conley now serves as a volunteer and medical contractor, and I know she spent some time up in Petoskey at the hospital there for the last few months. Edwin Dolan holds a PhD in economics from Yale University. He is taught in the United States at Dartmouth, University of Chicago, George Mason University, and Gettysburg College. He's also taught in Moscow, Russia, where he and his wife founded the American Institute of Business and Economics, an independent, not-for-profit MBA program. He's taught in several European countries, as well as the Stockholm School of Economics. Dr. Dolan is currently a senior fellow at the Niskanen Center, where he specializes in healthcare policy. Please help me in welcoming our first speaker, Dr. Barb Conley.
Well, thanks. Can everybody hear me well? Okay, I'm seeing the back row giving me a sign. Thanks very much for coming and participating in this, what I think is a crucial discussion for most of us. So what I'm going to really cover in my part is the Healthcare Voices, which is a group out of Northport that has been working on what is the lay of the land, basically, with healthcare insurance and healthcare. We'll touch on some of the outcomes that are now coming out from the Affordable Care Act use and Medicaid expansions. Some of the issues that we face as a rural center and some of the cost issues that I think may make healthcare unaffordable for even those who have healthcare insurance from their employment. And then Ed is going to tell us how to fix it. Okay. So I kind of like to start with a true story, and I searched everywhere for the place where I found this, and I couldn't find it, but it was in a medical journal. And it's the story of Andrew, who was a 27-year-old graduate student who was diagnosed with metastatic cancer. He had his insurance for the graduate student, which was perfectly fine for a healthy 27-year-old, but inadequate to cover a cancer diagnosis. Their pharmacy cap, for example, was $5,000 a year. And as any of you know who've been touched with this, that won't cut it for a cancer diagnosis. The lifetime coverage cap was $500,000. And so they had quickly to learn how to struggle to find the money to pay for his necessary care, which cost $300 a day. His annual drug coverage was exhausted in a few weeks, and his wife's 401k plan was exhausted as well. So he did finish his PhD in algorithmic robotics, and he got a job at the University of Michigan, which is no small feat. And his wife figured out only later that he did this as one last quest for health insurance, better care, and life insurance, so she would be taken care of. He never got a chance to set foot in his office. He died 3 months later. What happened to them 10 years ago is not allowed under the Affordable Care Act today. Healthcare plans are no longer allowed to have annual lifetime caps and are required to limit out-of-pocket costs. These improvements are under direct attack today, but even if they weren't, we still have a problem with the costs of medicine. So Healthcare Voices is the name thought up by Colleen here and Cooper, and they are composed of Ed, myself, and Colleen, and Yvonne Nordstrand, who's here today, Jerry Schatz, my husband, Kirk Richards, Patricia McGee, Mimi Heberlein, and others, because we had a concern of what was going on in our community. How was our community handling this idea of healthcare insurance? Why did we have this concern? It's obvious if you live here that there are many part-time workers. There are many part-time employers. In other words, they're not open in the winter. Many people are self-employed. So how are they dealing with all of this? And of course, there's a level of poverty even in this community. Access to health care also we were concerned about, because up in Northport it's 35 minutes to Traverse City, going fast on good roads. There are a few Medicaid spots are open because most practices will limit their Medicaid spots because they don't get enough reimbursement to float the practice. Some services are or virtually are not available in that they are full and no more people can be accepted. And transportation is an issue for many people. Sue mentioned I was up in Petoskey, and there were some patients who had unusual diseases and they needed to be seen at University of Michigan, they can't afford that. So we started talking to people, and from the so-called patient side, the consumers of the healthcare insurance, we heard several things about the Affordable Care Act, such as it allowed me to retire before the age of 65. It works pretty well. I can get care, but one year, because it goes on your tax returns, I got a $7,000 bill because I made more money than I expected to make. The premiums are high for our income. The deductible is over $5,000, but we pay the premiums and we still have to pay everything else because it covers catastrophic issues, which, as you saw with our story, it can happen to everyone or anyone. Some patients could not get into a provider that took Medicaid. Some people were on the Jesus plan. They just figure nothing will happen to them, hopefully, in the time that they haven't got health insurance. And one noted that he really likes the provision in the Affordable Care Act that says you can't charge more or you can't stop giving insurance because you have a pre-existing condition, because one of his friends at a young age was diagnosed and cured of testicular cancer. Other issues from patients: there was a year wait for a pain clinic appointment. Despite Medicaid, some people cannot afford the medications or the lab charges because Medicaid won't cover everything. It's difficult or impossible to find a provider that takes Medicaid for maternity care, which can run $1,500 to $7,000. Transportation, again, was an issue. Access to specialists was limited for some people. And there are issues with getting the appropriate medical care for children who are adults that have medical needs. And then one patient is saying, I didn't sign up because I didn't want to pay for others. Talking to providers, they have issues too. There's too much administrative burden. As we heard last February from Kevin Seitz, just Blue Cross Blue Shield has 100 different programs. And if you're a medical provider, you have to deal with all of them from Blue Cross and Blue Shield, plus everybody else, Priority Health, whatever else. There's also too much money in healthcare, besides the providers and the insurers and the drug providers. There are a whole bunch of other people that make money because of our healthcare system, and it gets confusing. There are few resources for mental health care. I think this is a nationwide problem. There's little available dental care for anybody who has Medicaid, and those of you who think that's a luxury, it might be, but on the other hand, you can certainly get septic and eliminate your heart from dental infections. Inability to get patients to specialty care was an issue, not only because of the transportation issues. Some of the specialty care is at Mayo Clinic or at University of Michigan or somewhere else. And the Department of Health and Human Services of Michigan has noted that many people do have Medicare, but they can't afford Part B, which, as you know, pays for all the outpatient costs, and it only pays 80% of outpatient costs. So some people have it, but they can't afford that 20%. Some employers can provide health insurance of various levels, and some cannot because they just can't afford to pay a living wage plus the cost from health care insurance. Michigan is a state that did expand Medicaid, and so this has been seen as a lifesaver for most people, I think, both by the providers and by the patients. You can be eligible for this with an income of about $16,000 a year, but above that, you're not eligible for it. The subsidy is determined by tax returns. The State Children's Health Insurance Program, or SCHIP, is still functioning, thank goodness. It was a touch and go there for a while, but it's still functioning. The Michigan Department of Health and Human Services can help some low-income seniors with Parts B of Medicare, and Medicaid can kick in something for Medicare, but it's very complex. And if you talk to people about this, you can quickly get confused. The Social Security Administration can sometimes help with Part D, which is the drug coverage. Part D, I think, by most people is seen as it's not that helpful. It doesn't do anything with costs. And you kind of have to know what you're going to get sick with when you sign up. If you have disability and you're adjudicated as a disabled person by Social Security Administration, it's still 2 years before you can get onto Medicare. And so for that time, if you can qualify, you'll be on Medicaid, and if you can't, you're on the Jesus plan, I guess. Now, it hasn't been that long since the Affordable Care Act has been ramped up and functioning. It started basically in 2014, and so we're just beginning to get some of the healthcare outcomes from that being in place, and also from the Medicaid expansions. So what we have as an outcome is now more cancer patients are insured versus not insured. In the expansion states, the uninsured cancer patients went from 9.6% down to 3.6%. In states that did not expand Medicaid, they had more uninsured to begin with, was 14.7%, and they made a tiny progress somehow to go down to 13.3%. But the most important thing is that there has been a statistically significant shift toward diagnosis of early stages where cancer is curable. Even now, they're noticing this. And another area, more access to substance abuse services because of the Affordable Care Act, and Michigan was able to increase the numbers of those who can receive this by 14%. And now that we're having 30,000 deaths a year from opioid overdose, this is important, as well as all the other substance abuses that people are heir to. Now, affordability, I mentioned at the beginning that I was concerned that we wouldn't be able to afford health care no matter how good our insurance was. And those of you who have insurance from employers have noticed that there's more that you have to pay. You have to pay more in the premium, your share of the premium, and you have to pay more out of pocket than you did 10 years ago. So big companies are worried about this too, and there's this Health Transformation Alliance, which is 40+ companies, and they have insurance for their employees of 6 million employees. And they have decided they've noticed that in 10 years, more than half of these employees who are heads of families are predicted to be not able to afford health care at all with their insurance, because it will consume 9.7% of their household income. So what they have done is they've pulled together, and they're going to mine all the data from all of these companies as their insurers bring it in, and they're trying to find efficiencies about this. But I just thought it was kind of helpful to know that from the employer side, some people are working, they understand this is going to be a crisis, if not already. In Michigan, we do have the ACA, and we elected to go with the federal program. We do have 8 insurers in the health marketplace. There are 12 to 52 plans offered in each of the 83 counties. As you remember, or maybe I'll remind you, there are bronze, silver, and gold plans, and each of them has different deductibles and different co-pays and different premiums that you have to meet. So these, across all counties, the premium increase in the middle plans was 30 to 35%. That's a lot of increase, I think. And the premiums for the lowest cost bronze plan also increased by 16%. The gold plans only increased by 6%, but they're kind of expensive to begin with. Now, there are tax credits that people get for this, and so basically a lot of people who are within the like 130% of poverty level, they might not have to pay so much, but there are also tax credits. And the way they adjusted the law this year, it goes by the second lowest price silver plan. So basically those people who had that or above, actually they're getting a little more subsidy or tax credits than they were before 2017, 2018. Now we are in, I think people would agree, is a rural area. We don't have any big cities nearby. And people are paying attention nationally. The Centers for Disease Control and the National Cancer Institute looked at rural areas for their situation with cancer and cancer care. And they found out that people in rural areas don't get cancer quite as often, but they die from it more frequently. And they think that's due to access, less clinical trials, that kind of thing. There's a lack of physicians up here. It is tough to recruit a physician up here. I don't understand it, but anyway, it's tough to recruit a physician up here. And there's a lack of resources, there's a lack of, as we're going through the Medicaid, people who accept Medicaid, the mental health resources are very, very lacking in this area. I think it ties into the lack of physicians. There is poverty in this area. 6% of seniors in our area are at poverty level. In Northport, 53% of the school children qualify for a free lunch. People probably wouldn't have thought that was the case, but it is. Now, I talked a little bit about costs, and I'm going to talk about something that I know. And the cancer docs have really gotten together and tried to figure out how we can make these drugs cost less. I was just reading about a different drug, not a cancer drug. It's for some very rare retinal eye condition, and they priced that drug at $850,000. So, how do you afford that? But I'm going to talk about a lifesaver drug, one of the first precision medicine lifesaver drugs that there were out there. And this targeted a molecular abnormality that is present in people who have a rare disease, which is chronic myelogenous leukemia. It took their life expectancy from 3 to 4 years with toxic chemotherapy to almost normal, with much less toxicity. This drug was approved in 2001. It was priced at, FDA doesn't price it. The company priced it at $26,000 per year. But the cost eventually rose to $146,000 a year. That's fine. So then it comes off patent, right? And you get generics. But the generics are priced at $140,000 a year. And there are 2 or 3 other drugs that actually can do the same thing, and they're all priced in the same ballpark. Interestingly, you know, if you have a whole lot of competitors in the computer industry, the price tends to go down. But here the price, well, hopefully, this doesn't mean that the price was controlled, but it didn't seem to go down. And in Canada, you can get the same drug for $8,800 a year. So, of course, how our healthcare goes some other things in our life, right? The affordability of housing. Do you have to choose between housing and food and healthcare insurance? Attracting employers and employees. It matters if we have access to healthcare and if we can afford to provide that as a benefit. Attracting healthcare providers. You know, people might not want to come to a place where they can't run their office, they can't make ends meet, that kind of thing. And of course, the health of the community. So, as we considered these things, the healthcare voices, we came to the conclusion, a little broader than what the League has put out, is that everybody needs access to healthcare as needed. Not just primary care, because that won't do you a whole lot of good if you have a diagnosis and get sick outside what the primary care cannot handle. Also mental health care. This affects all of us, right? Not just the person who needs the care. Dental care and preventive care. They're not preventive care for everything and everybody, but there are national bodies that consider whether preventive care is helpful. And so we should go by that. There are also, you know, considerations of what care is effective. And we should consider those things and provide that to patients. We have to control costs. I don't think we can provide health care to everybody without some way of controlling costs. And this is where we consider that there are more than one way to get there and that we actually can afford it. There's a nice little editorial in The Economist recently that says, yes, universal health care is possible and we can afford it. But we might have to get creative. So at this point, I'm going to have Ed come up and continue the dialogue.
So, I'll just thank you, Barbara, for that. take us from a regional perspective to more of a national perspective, and talk about some ways we might possibly improve our healthcare system. This is a diagram which some of you may have seen before, which suggests that the United States could do better than it's doing. It shows that compared to 11 leading countries of comparable levels of income, the United States has a low level of healthcare performance in terms of outcomes, access, equality, and other criteria, yet spends much more on healthcare per person. So there's room to do better. The question is how and what exactly does doing better mean? Well, as far as what doing better means, a good checklist is provided by the League of Women's Voters national position paper on healthcare. The key element of doing better means access to a basic level of quality care at a price that is affordable for everyone. Universal healthcare access. Universal healthcare access would improve the system performance for the United States, because a lot of our low performance has to do with people who either have no health care coverage at all, or have limited access, or who have access but have to cut their pills in half because they can't afford them. I'm sure Barbara knows all about that. So part of doing better also means some cost control policy. The League of Women Voters has an open mind on several aspects of various ways to go about improving the healthcare system. For example, the position paper says that co-pays and deductibles can be an acceptable part of the program, provided that they are based on ability to pay and not structured in a way that excludes anybody from coverage at all. The League of Women Voters is open to the idea of a national system financed by general taxes. National system as opposed to a purely state-run system, but still some role for the states is possible. And the League of Women Voters is also has an open mind on the issue of whether or not which parts of healthcare system are provided by directly by the government, and which parts by private providers. So what I'd like to do is look at three different programs, three different actual policy proposals that are on the table now and being discussed, that take somewhat different views on some of these issues. Public versus private providers, how much cost sharing, and these